into that link.
All right. Well, hello. Welcome. Come on in. Great to see you guys. Great to see you. Before we get started, as people file in, I wanted to make you aware that, well, first of all, so this is a live question and answer. You post your questions in the chat, and my assistant, Daryl, will post the questions and I will answer them. And if it's something that's beyond the scope of what I do for a living, I won't be able to answer it. And it doesn't always have to be something medical. You could ask me something personal, as long as it's not too personal. All right. But before we get started, also, I just wanted to make you aware of something that I saw yesterday that was exciting to me. It's new news in the psychedelic world, that a company that has been testing a derivative of LSD for anxiety has been granted breakthrough status from the FDA to move forward faster. That's what that's what breakthrough designation means. And this drug, in their first couple of stages or phases of their trial, one dose treated generalized anxiety disorder for up to 12 weeks so far. They're still doing clinical trials. So that's exciting to me. Generalized anxiety disorder is not easy to treat. And the thought of and most times people have to just manage their symptoms, reduce as opposed to go away completely. So I'll be interested to see just how effective, like, do the symptoms go away completely? That would be something outstanding, but we'll see. So I will, that's one of the things that I announced in my, or I made people aware of in my weekly newsletter. I like to keep people up to date on things that I hear about. If you want to stay in touch with me or stay connected and also hear about things like that, you can sign up for my email list at getmentalhealthtips.com. That's getmentalhealthtips.com. It's on the screen there for you. And it's free. It's just me sending out information each week. All right, so I also plan to have an upcoming video explaining more details about the new medication and what the next steps for that will be. All righty, let's get going. All right, Pama, thanks for your question. Do you know cases of people successfully overcoming gambling addiction and how they do it? So no, I don't know anyone, or I don't, actually I do. No, sorry. So I don't know any cases from like experience of people who've overcome. I've known people who have been in treatment for it. And just like with any of the other addictions, particularly like substance abuse or substance addiction, people go into remission and there's still a risk of relapse. That's how it is with addiction. Most addictions, if you go to like an AA meeting or something, you'll introduce yourself as still an addict with the vulnerability to have a relapse at some point. I would think that gambling addiction would be a similar setup where you can go into remission and stay in remission, but it's still a vulnerability that something could trigger you to get started again and then have the trouble and have a problem again and relapse and then have to kind of get back out of it. As far as the treatment goes, It's a behaviorally based treatment approach, and the actual steps to that and what they actually do, I don't know, because I don't do that kind of treatment for behavioral addictions. I don't do addiction treatment, period, but behavioral addictions. Thanks for that question. All right, Maj. When do we know that we have anxiety disorder or not just stress? Very good question. So, an anxiety disorder versus just anxiety, because keep in mind, anxiety is also a response to, so we can all have anxiety. But when it becomes a disorder is when you have persistent anxiety symptoms that interfere with your daily functioning in some way or your productivity in some way, and it's not always triggered. So stress, let's say you've got you've got financial strain, you're out of work or something, you've got all these things going on that make you feel tense and anxious because you're worrying about how you're going to get through these things. Maybe you're having trouble sleeping, and that can go on for a while as long as the stressor is still pressing on you, as long as it's still an issue. But that is more situational anxiety that's not necessarily a disorder, because once the situation passes, presumably, if you don't have a disorder, your anxiety symptoms also pass. Versus the person who has an anxiety disorder doesn't need a stressor to have similar symptoms. So something stressful going on can make their symptoms worse or aggravate their baseline anxiety disorder. But even in the absence of a stress, they could be on vacation and still wake up with chest pain or wake up feeling nauseous, or struggle with nausea all day for various reasons. So, and not always be aware of why they're feeling that way. So that's kind of one way to make the distinction between symptoms that come because you're under stress versus anxiety related or anxiety type symptoms that come with no stressor, worse when there's a stressor, but still present when there's none. All right. Oh boy. I see you in watch 79. Thanks for your question. I'm addicted to Dr. Tracey Marks videos. Is that healthy? That's a good one. I like that. I'd like to think it's healthy. I'm yeah, keep watching. Thank you for that. JW, is Adderall a medication that is to be taken as needed or every day? Thanks for that question. So, so the need for a stimulant. Okay, so Adderall is a stimulant that we use to treat ADHD, attention deficit hyperactivity disorder. That's the main reason we use Adderall. It's kind of used sometimes in other contexts as well. The problem of ADHD is a daily problem. It's not just something that comes and goes, that pops up and then kind of goes away. However, for some people, it can be more problematic under certain circumstances and not as problematic at other times. For that kind of person, that person may do better only taking the stimulant under certain circumstances. So let's just give you an example. So let's say with your ADHD, you recognize that your biggest weaknesses are sitting in meetings and listening to people talk. You cannot focus on someone talking. Yeah, that's the main thing. Like, you can't do meetings, but you can, if you can, sit in your office with your door closed, you can get into your zone. And here's another one. And then, but if people are interrupting you a lot, then you're just, it's over. Okay, so knowing that, if you have more control over your schedule, such that on, every afternoon you have meetings, or you have meetings 3 afternoons a week, then you might be someone who decides, okay, I will take my Adderall only 3 days a week at work, or I'll take it Monday through Friday, and I'll take the immediate release just in the mornings on Monday through Friday. But then on those 2 afternoons a week where we have meetings, I will also take that second dose. Why would someone, I know this isn't your question, it's my follow-up question. So why would someone even want to do that? Like, why not just take it every day? Because for some people, tolerance is not an issue. I have some patients who've taken the same dose for years. But for many people, that's not the case. If you take it every day, after a while, what used to work, the dose that used to work, isn't as effective. So taking a break from it, whether that break just be like weekends only, you get off and then you start back on Monday, or just kind of random days that you don't take it, that slows down the tolerance process. So I usually recommend for my own patients that if you can find times where you don't need to take it, then don't take it if it doesn't cause problems for you. There are some people who will get into a car accident if they don't take their stimulant because they're not paying close enough attention. So for that person, if you drive every day, you should take it every day. So another downside, and I've seen this quite a bit in taking it every day if you don't need it every day, is if you say go on vacation, the withdrawal, and you decide, I don't want to take Adderall on vacation. The withdrawal effects from getting off of Adderall or being without it after you take it consistently can either be extreme irritability or extreme fatigue, like you can barely get out of bed. So you could, and I've seen this, someone takes it most days or every day, goes on vacation for a week, and they feel like they lost the first 3 days of their vacation because they spent it super exhausted and not being able to get out of bed. And some people just give up and just be like, well, fine, I'll just take it on vacation because I want to enjoy my vacation. So if that person, though, was more in the habit or their body was used to on, off, on, off, on, off, it wouldn't be such a dramatic change for them to go on vacation and go 7 days without it. So it really is a personal decision whether you take it every day or not. I just tried to outline some reasons to not take it every day if you don't have to. Thanks for that question. All right, MP, let's talk about it. Thank you so much for the super chat. I don't know why I have to put on my glasses for this one, not the other one. Thank you again for the super chat. I really appreciate it. As a 24-year-old man going through financial hardships, family dysfunction, and life problems as a young adult, what would you say is the best way to handle the stress or keep the stress levels low? Okay, so handling stress for someone who is having financial hardship and family dysfunction. Okay, so that's, I always say multifactorial in that there's not going to be one thing that does it for you. I will say, so if you have very little control over some of the stressors, so the stressors, in this scenario would be the financial hardships, the family dysfunction, whatever that is, maybe family relationship issues, people not getting along, something like that. I'm just kind of guessing. Those are things that you may or may not have much control over. I would start at what are the things you do have control over? Are there ways to minimize contact with some of the people who are causing drama or maybe toxic or things like that? Trying to find ways to protect yourself by lessening your exposure. Then, with the financial hardships, that might also be a situation where you have very little control, or maybe you do have some control over it. Trying to find ways to intervene and make adjustments for the things that you can control, even if those things that you do don't eliminate the problem, because that's not the goal here, is just make stuff go away, because this is life. It's to make it more manageable. So that's one approach, is, from the top down approach, looking at the problems that are causing you the stress and seeing what you can control and what you can manage with it to reduce your exposure to those things. and get some relief from them. Then the bottom side up approach would be, then how do you manage how do you deal with how it affects you? So then it's still kind of taking the approach of self-protection and and self-care, really. So trying to maximize downtime or carve out time that you can recharge or have time to yourself. If you're the kind of person who needs peace and quiet to feel rejuvenated, the person who tends to be more introverted needs quiet time in their head and time to think. And so if, not having any of that, or you find yourself, you're doing this, you're always thinking about this, you always have stuff to do. For that scenario, it's about trying to compartmentalize things in a way that you can still reserve some time to be able to get out of depletion mode and rejuvenate and feel more, fulfilled. That time could be just spent quietly or doing stuff that gives you pleasure, because you have to have some balance between stress and hard work and things that satisfy you and make you feel good. If you're more on the extroverted side, where you gain energy from connections with people and doing things with people, it doesn't mean that the person is introverted doesn't like people. So I just want to clear that. But you get to, the extrovert person can be more depleted from isolation and not being able to talk to people and things like that. So for you, it would be, instead of trying to carve out time yourself, it's carve out time to spend with people so that you can fill your cup back up. So the moral of the story is trying to manage the stressors as best you can, and then also trying to find ways to keep your cup full so that you can, put on your armor and charge back out there and, slay through the day, another day of this stuff. And then, come back home and do it all again. But you can't keep doing it if your cup isn't full. That's my generic answer to that. Thank you. All right, DK says, hello, Dr. Marks. What treatment do you suggest for constant rumination? Constant rumination. So I'm assuming, DK, that you are talking about depressive rumination, because oftentimes that's kind of what we associate with ruminating. But some people will categorize excessive worry and fretting as ruminative thinking as well, regardless of which one. No, I shouldn't say regardless. So if it's more in the depressive mode, like, I'm not good enough. Things where you're thinking negatively about lots of things, whether it be about yourself, your situation, and making all these assumptions and going over and over in your head. If you are not depressed, like if you're talking about what do I recommend from a non-medication point of view, so medication point of view would be, if you're depressed, get evaluated to see if being on an antidepressant would help you, because helping your depression would then also help the rumination. But you're still left with that is your tendency when you get depressed to ruminate. So to break the cycle of that, you would look to do things that kind of break up, I guess, distraction. So ways to distract your thoughts from kind of going in that direction. Kind of what I was just getting hung up on was, trying not to get too detailed here, but so a part of our brain called the default mode network is structures in the brain that click on when we don't have anything else to think about. So when we're not intentionally thinking about something, you kind of go into this, okay, your brain will just give you something to think about. So people who tend to be more ruminative, their default mode network just kind of goes crazy with stuff, whether it be anxious thoughts or depressive thoughts, to keep your mind occupied. Okay, so you want to do things that keep your default mode from turning on. So mindfulness, I probably say that a million times all the time. You've probably heard it a million times, but mindfulness is really just the state of being fully present in the moment. We tend to mindlessly do things. So I'm driving to work and I'm thinking about the stuff I have to do later, versus driving and focusing on, well, I am focusing on the road, but like focusing on the traffic in front of me, the color of the car in front of me, the temperature in my car, how comfortable is my seat cushion, like all of these things that have to do with what I'm presently doing versus future thinking or future planning. So the more we tend to future think and future plan, the easier, the more the tendency to then start worrying about stuff or negatively thinking about things. So getting into the practice of bringing yourself into the current moment of what am I doing right now? It could be washing dishes, instead of washing dishes and thinking about, I should have spoke to this person. I should have done this. And then while you're washing dishes, think about the way you kind of zone into mindful thinking is to use all of your senses and kind of do like an inventory of what your senses are experiencing. So if I'm washing dishes, the color of the plate, the temperature of the water, is it steamy? The slipperiness of the soap, focusing on that kind of stuff, focusing on all those little details, including engaging all of your senses in that, keeps your mind off of all of that other stuff. Now, granted, you can't just always walk around. You've got to do some planning. You do have to think about what time do I need to start getting ready if I'm going to leave to show up on time for something. But still, that is focused thought on that. What you're trying to do is get out of your head when it comes to playing back scenarios, or I don't know exactly what you are ruminating about, but generally it can be self-critical things, thinking about things you did, should have done, didn't do, all of that stuff. So putting yourself in more of a mindful frame of thought when you find yourself thinking this way is one thing. Other types of, and then, there's just getting more involved in activities that distract you, whether that be taking walks, exercising, doing your chores around the home, but focusing on that chore, that kind of thing. So long story short, it's about distracting yourself and getting out of your head and focusing on the moment. That would be kind of one thing I would suggest for addressing ruminative thoughts, and as well as the anxious thoughts as well. I know I focused on the negative ruminations, but the anxious thoughts as well. Thank you for that question. Tiger Lily, so happy you're doing a live now. Thanks, Tiger. I'm glad you're here for it. May Chan, love all that you've ever done. Thank you, May. Silly, weird question. What's the best type of therapy treatment for depression caused by an incurable disease or lifetime disease? So, I may not be able to give you the best answer, May, because there are so many therapies out there. So let me see one more time. Depression that's caused by an incurable disease. So, I'm pausing because there's kind of two approaches to this. Well, two answers, kind of. One is, this may not be where you're going with this, but just because if you have depression, it when it comes to treating it medically, I know you're talking about therapy, but medically, it doesn't matter as much the cause for it. It's not like it's a different kind of depression because it came from an incurable disease versus a biologically based depression that is not connected to any kind of physical ailment. Okay. If it is connected to a physical ailment, then yes, treatment also um, is your treatment also requires that the physical thing also be treated. Okay. So that's kind of the main difference there. But I just want to, I'm saying this because I don't know if part of your question is, well, if you get depressed because this happened, does that make your depression different? Okay, so past that, as far as like working through your depression, I would think someone who is focused on grief, kind of, because even though it's not grieving the loss of a person, you are grieving, you may be grieving the loss of your previous health status. If you've got something that's incurable and it's something that causes death, because in theory, a lot of stuff is incurable. Depression isn't curable. You can go into remission, but it's not cured in the sense that you get it treated and then it never comes back. It might not for some people, but many people it does. It's a recurring illness. But if you're talking about a disease that causes death, then you've got to cope with living with something that is going to end your life sooner than you expected it to. There's also therapies out there that focus on illness, managing chronic disorders that don't necessarily cause death, like chronic pain and things like that. I don't know that those have some specific name to them. There might be, but I just don't know what those names would be because there's therapies coming up all the time. But I would say, if you were looking for a therapist, the best way to just do it rather than trying to figure out what kind of therapy and trying to find a therapist who does that, you could look at a therapist who works with people dealing with chronic illnesses and managing their lives through those chronic illnesses. And that person should be able to tell you if they're equipped to do that. And one more thing about that, probably the approach or one approach would be from a cognitive behavior perspective or point of view, because you're changing your thoughts about or managing your thoughts about having this illness and what your life and outlook is because of it. And then you may need to change some behaviors that are not serving you well because of having this illness. Okay, that's a high level view of the kind of therapy. Okay, Kilspany 7. Hi, Dr. Marks. Love all your videos and have been a long-time subscriber. Thank you. How can I reframe my tarnished character acquired from negative experiences and people's opinions who keep blaming shame? Oh, wow. Okay, wait, hold on. Let me read this again. The power of the internet and mental health information. People are learning more. This is great. Okay, so let me get back to this. How can I reframe my tarnished character acquired from negative experiences and people's opinions who keep blaming shame? So if I'm hearing you correctly, you're saying that people shame you with criticism and negative opinions of you and things, and I take it they're saying this to your face. And how can you? So where I'm stuck is, how can I reframe my tarnished character? Character in your own eyes, like how you see yourself, or character based on what people think about you because of what other people are saying about you? Um, it's hard. You can't really, um, you don't have a lot of control over what other people are going to think of you. You just have to do your thing, shine your light, and if they see it, they see it. If they don't, they don't. However, if the issue is more that uh, people, you started to believe what people say because they just make you feel bad, and you start to kind of, that becomes part of your own narrative of this is who you are. Um, Reframing that for yourself, uh, I don't see it as reframing. I see it as blocking um, what people are saying because you don't need them to show you or tell you who you are. If you don't have a good sense of who you are, what you stand for, your strengths, then it's going to be easy to just let other people assign those things to you, and tell you who you are, what you stand for, and focus on your weaknesses. So perhaps if you struggle with that, of like, um, you know, accepting or owning shame, the stuff that people say, people's criticisms, and feeling shamed all the time, um, I would say one of the ways to dig out of that is you to focus on your strengths because we all have weaknesses. And so, people can shout my weaknesses all day long. It's still going to make me feel bad. But I don't have to live in that every day of, yeah. So you're going to focus on the fact that I can't do this, but I'm going to focus on the fact that I can do this other thing. And yeah, I can't do that other thing. Okay, we can't do everything. No one can do everything. So I'm going to, you need to find a way to thrive in the things that you're good at. And this kind of goes back to an answer I was saying about another question, which is minimizing exposure to the things that you're not good at. So if you know that you're not, it's hard to kind of not have a concrete example here, but if, see, I'm trying to think of one where, a shaming comment, but if I know that I'm not good at this thing and somebody's always kind of, you didn't do this, blah, 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 or something, and, I feel bad, um, I'm going to want to minimize my exposure to those people. Now, maybe I can't. Maybe there's somebody that I live with or work with every day. So it's going to be about trying to see the fact, going back to the reframing. I'm sorry, I'm kind of all over the place here, but um, you don't want to diagnose people, but at the same time, you can't ignore what you see in front of you. People who need to shame you need to do that because that's what they need to feel good about themselves. So if you see someone make a mistake or do something bad, um, yes, you can give people negative feedback because it may help them. But if you need to put somebody down or step on them, like what's the value in that? And when people do that a lot, it says more about them. So even though I get that, yeah, kind of like that, 16 stones may break my bones, and that doesn't really make you feel better, saying that little ditty. Um, Still, the truth is that I guess a way you could reframe their behavior is to see it as, sadly, this is what this person or these people need to do to kind of validate their own insecurities and even make you look bad, because what making you look bad makes them feel good in some way. That's that. But you're not going to be able to change that, and you're not going to be able to fix people and get them to not do that. So what you have to do is just keep saying to yourself, it's them, let them say their stuff, but this is me, this is why I feel good about myself, and reinforce these positive qualities in your that you see in yourself by doing more things that reinforce that, yeah, you're good at this, and so that's why you're doing it. So it's about, again, it's going back to exposure, maximizing your exposure to things that operate in your strength, people who lift you up, minimizing your exposure to the people who try to tear you down and block owning the stuff that they say, even if there's a little bit of truth in it. But again, we all have weaknesses, but someone throwing your weakness in your face to make you feel bad, it is their problem, that they have to handle it that way. Okay, I'm rambling. I hope that was helpful.
This is Tracy's now. Your mic is sounding a little low and staticky.
The mic is low.
Yeah. Yep, it's low.
Okay, so I'm going to switch. I'm having a mic problem.
Let me try some stuff on my end.
Okay.
All right. Okay.
1, 2, is it better?
No, it's still low. All right. Unmute your mic on your end.
Okay.
There we go.
Is that better? Okay, so I do have, I'm using my webcam mic right now, and then, yeah, that's the only one that's working. Okay, let's do it that way. Sorry about that, guys.
All right, let's ask the chat. How does she sound?
Can you guys hear me? Probably has the room echo, but
That's all right. They can hear you.
they can hear me. Okay,
Yep.
great. So let's continue. Sorry about that staticiness. Technology.
Exactly. All right, here we go.
All right. All right. Claudesia, thank you for the super chat. Hi, Tracy. Been following for years. Thank you. I used to suffer heavily with panic disorder and agoraphobia. Your channel saved my life. Today, oh, that's wonderful. Thank you, Claudesia. Today, I'm going to school to be a psych nurse. Awesome. Thank you for letting me know that. Like, I was talking to somebody just the other day, and I was just saying how, like, hearing stories like this about the impact of just getting basic mental health education is just, gives me so much satisfaction and pleasure. Oops, oh, my bra strap showing. Sorry. I just like it just doesn't get any better than this. for me. So congratulations, Claudia. I'm so glad your panic is under control now. And also, I'm glad you're going to be a psych nurse. We need more of you. Thank you. Tint Braille, thank you for the super chat. Will increasing dopamine and serotonin help me with social anxiety, and what could I take? Increasing dopamine and serotonin with social anxiety. All right. So thanks for that question, Tint. What we have seen with anxiety, the most helpful neurotransmitter is serotonin. So the medications that we use to treat anxiety for the medications that we use to treat anxiety are the antidepressants. The only antidepressant that also increases dopamine is Wellbutrin. Bupropion is the generic name. It can help some people, but it's not the best because of the fact that it's stimulating. It can make anxiety worse. So I would not think that focusing on increasing dopamine helps anxiety, except anxiety that's brought upon from someone who's got ADHD and has low dopamine levels in certain parts of the brain. And because of that, kind of like the downstream effect is anxiety. So there are some people who have ADHD, it's untreated, they struggle with it, and they have a lot of anxiety. This isn't and that's not social anxiety, but have a lot of anxiety. They get their ADHD treated and their anxiety resolves. Okay. Social anxiety could also be treated with beta blockers. Okay, so wait, before I do that, sorry. So going just to kind of finish that train of thought though with the serotonin enhancing agents. So the antidepressants that increase serotonin. So that would be the serotonin reuptake inhibitors like Prozac, Lexapro, Zoloft, even Cymbalta or Effexor. All those are serotonin enhancing antidepressants. Beta blockers, on the other hand, are medications that are used to treat like blood pressure, heart issues, and things. In psychiatry, we use it it reduces adrenaline. So we use it for people who have physical symptoms with their anxiety. Where this could tie in with social anxiety is if you tend to like have serious trouble like going in a group and then having lots of heart racing, flushing, could barely speak. Social anxiety is called social and performance anxiety. So it's not always about being around people and second guessing yourself and worrying about what people are thinking and so on. That's one aspect of it. Another aspect, the performance part, is being unable to do stuff in around other people, like speak in a group, or any kind of performance, even work with people looking at you or something like that. So in that scenario, if you have a lot of physical symptoms that then make you kind of just collapse under the pressure and not be able to perform, things like taking something like propranolol is the typical one that we will use, maybe metoprolol, but or sorry, Pendolol is another one that will be used, not so much metoprolol, but propranolol is kind of the go-to. It will change your physical symptoms. So it will like reduce your heart rate, keep you from flushing in front of people. And if by doing that, if by controlling your physical stuff, that enables you to go ahead and perform, whether that performance be talking to people or whatever it is, then that's another way that your social anxiety could be treated. The thing though about going the beta blocker approach where you're treating the physical issues, it does not really address what's going on in your head though. So if your social anxiety is really driven more by thoughts about what people are thinking and trying to anticipate what they're going to say and making assumptions about their people are judging you and that kind of thing, it doesn't really do much for that. And that's where the antidepressants tend to work better for that. All right. Next question. Thanks for that. Okay, Kai Wen, I think that's how you pronounce it. Thank you for the super chat. After a trauma of losing a loved one from a car accident, oh, I'm sorry about that. I was not even in the car. I now have panic attacks when I drive. Is exposure therapy the best treatment and how should it be done? Okay, thanks for that question. Again, I'm sorry for your loss. And you can develop post-traumatic stress symptoms, whether or not it's the full-blown disorder or not, but you can have a trauma reaction even when you were not in the car, kind of either from witnessing or even learning about, the death of someone or someone being attacked. So this is not uncommon to kind of end up having this reaction. So exposure therapy, yes, I would say of the trauma-based treatments, probably exposure therapy would be the best one. And the way it would be done is your therapist would come up with, assuming you have a therapist, would come up with kind of like a graduated schedule of what you could be doing. So you're just going in little baby steps. So let's say, and that person would start by finding out the circumstances of the panic attack. So is it the distance that you're driving that triggers the panic attacks? The further away you get from home, the more you start to have it. Is it when you get on the highway? Is it only at traffic lights? That kind of thing. Like, look at the circumstances that trigger your panic attacks. What makes your panic attacks better? Is it only after you just like pull over and that's what does it? Or is it something that you do? Those little details would factor into how the exposure exercises would work. So let's say for you, it's you're okay driving around in your neighborhood, but it's when there's a lot of cars on the road, or it's in an intersection, let's say that. It's when you get to an intersection, you start feeling your heart race. You're not sure if you should press on the brake, even though the light's green, like you get all freaked out. And maybe you start to dissociate, like feeling like you're floating, and now you feel like you're going to have an accident. Okay, hypothetical scenario. The exercises then would be like, this is just hypothetical, spend 10 minutes driving around your neighborhood. Like, and let's say you say, well, that doesn't bother me. Okay, that's okay. Do that. Then the next level would be, turning onto a certain kind of road nearby, still kind of keeping it somewhat safe. You're still not far from where you feel safe. You kind of want to, so what I'm doing is coming up with steps that get increasingly more scary and threatening for you. So let's say again, if the hot button is the intersection, you're going to do exercises that practice getting close to an intersection first. And then it might be, step number 3 or something might be going through an intersection, then you pull over, you manage your anxiety, you breathe, you do some grounding exercises, whatever it is that would address the anxiety you feel from that. And then come back home and then do it again. And you keep doing it until you feel more comfortable with it and are having less anxiety. Now, it might not get to where you have no anxiety. You still might be like going through the intersection, like, but you make it through, as opposed to you're not hyperventilating. You're not like seeing like blinking lights or, flashing lights in your eyes and things like that. Like, none of that's happening, but you still feel some angst. Okay, that's progress. Then the next step might be, okay, that was a little small intersection. A small intersection might be a 4-way stop with no light. A bigger intersection might be a light, but it's still a small, not a lot of traffic. And then you graduate to a much larger intersection. So that's just, so the idea is that, again, you are finding steps that are increasingly anxiety provoking for you, and you keep doing them, and you do each step over and over until it becomes, until you become desensitized, because it's like old hat now. It's like, okay, I got this. And then you move to the next one. That is probably, that it's not hard to do. I mean, sorry, it's not easy to do. It is hard. And it can take a while. So you have to be patient. The practice would be like, preferably every day, but certainly multiple times a week, that you keep practicing to then get to the next level. And yeah, it could take, you could backslide, and like be good at one point and then take some time off. And then you go back to that intersection, like, I'm getting that feeling again. And then you've got to kind of go back a step and practice that old step again to then advance to the next. So all that to say, this is something that could take months. A second option would probably be EMDR, but in EMDR, eye movement desensitization reprocessing therapy, helps process trauma. It helps reprocess it helps your brain reprocess the experience to kind of to dampen down the hyperactivity of the of your response to it. So you have a heightened response to driving because of the way this affected you. The EMDR works more at the level of like changing how your brain sees this so that you don't erupt in panic versus brute force getting you to just keep doing this thing until you're desensitized. So, so that's that's a different approach. You might not like the exposure part. It just might be too hard to push through, in which case then EMDR may be a better option. Thanks for that question. Richard, hello, your videos are awesome. Thank you, Richard. Thank you very much. All right, Nurse Adrian, RN, been watching you since early days, so appreciate your presence. Thank you. I have quite a contingency of people who have been watching for a while, and that's wonderful, and that keeps me producing. Mila, when does aromatherapy videos are coming? Oh, funny. Because I love aromatherapy, and maybe that's why you're asking that. I did one several years ago. I could do another one. I could add that to my list of to-dos. I'd have to whenever I do a video, I like to have an angle. Like, why am I talking about this versus just, let's just talk about this kind of thing. And I don't know. So thanks for that suggestion. It's probably time for another aromatherapy video, like the one that I did was several years old. So thanks for that suggestion. Brian, thank you for the super chat, Brian. Good morning. Morning. Doctor, I've recently been diagnosed with ADHD as an adult, age 31. I hear many pros to taking medication for ADHD. Are there any cons that I should be aware of before seeking medication? Love your channel. Thank you for this info. You're welcome, Brian. So, yes, there are cons to taking medication. There's cons to taking any medication, actually. And here's the cons. Hold on, let me get a sip of water. So, the mainstay of medications, Brian, for ADHD are non-stimulants and stimulants. Okay, so the stimulants, the two main ones out there, or I shouldn't main ones, the two out there are Strattera, atomoxetine is the name, generic name, and then Qelbree, it's spelled Qelbree, and I forgot the generic name for that. It's still brand. It's only been out a couple of years. Both of these drugs you have to take every single day.
and they work to improve, to increase dopamine in your brain, but to then improve your focus, attention, motivation. And in fact, I did a recent video not too long ago talking about Qelbree, that some studies have shown when they were comparing it to atomoxetine, Strattera, that it was better at addressing some of the executive functions than even Strattera was. I think that the stimulants are not that great at addressing executive functions. Some executive functions, so it's good at focus, concentration, and motivation, which is an executive function, motivation. But the time management, organization, those things, not quite so good. The stimulants are easier to take in the sense that you don't have to take them every day, kind of like I was talking about earlier, for someone who has chunks of time where it doesn't really matter if they're not that focused, so they can go without the medicine. And they work quickly. So they work within like half an hour to an hour, and they work for a certain amount of time, and then it wears off and you're done. So for someone who kind of likes to have a little bit more control over how long something is in their system, and I guess, my population of patients, I have a number of people who feel that way. Having something that's kind of like an on-off switch. I take this, it works, it's off, and I'm good, I'm fine without it. Then the stimulants are a good option for you that way, because you have more control of when you take it and when it's effective. A downside, though, is that some of the stimulants people can feel an emotional crash afterwards, and that can be a really big deal for some people. I've seen it more in children and adolescents. I don't treat children, but seen it more in like the adolescents, and I think it's because in young adults, and I think it's because of the still developing brain. I think kids and young adults just take a bigger hit when it comes to the effects or the withdrawal effects of the medicine or the wearing off effect. But yeah, some people, they'll experience an emotional crash when the medicine wears off and they can't stand that. So they may take a long acting medication. I've still had some people say, though, that when they take it, it makes them feel down. So they don't necessarily have the crash with the long acting one, but they'll feel like their personality has changed, like they're not as expressive and things, and that they don't like that. I do think I've had a couple people report some sexual side effects with the stimulants. So from that point of view, you're just looking at, as far as a downside to taking stimulants, just medication side effects. Every med can have a side effect. And I guess an upside is with the stimulants, where you don't have to take them every day, you can quickly get a sense of whether you like them or don't. And if you don't, then you just don't take them anymore. It's not like with Strattera or Qelbree, you've got to take it every day and you've got a buildup effect, kind of like antidepressants. And so it may be a few weeks before you see both the improvement as well as get a sense of how it makes you feel. So it takes a little bit longer to sort that out than with the stimulants. It's kind of like taking pain pills. You take the pain pill, the pain goes away, it wears off, the pain comes back. With the stimulants, it's kind of like that. You kind of get immediate feedback without a lot of long-term effect if you only take it for a little while. So if you're going to experiment, or I guess I shouldn't say experiment, if you're going to see if you think you like or want to take a medicine, the stimulants are the easier ones to get a quick sense of, do I like this or not? And keep in mind, if you are going to go down this road, there are multiple types of stimulants, and they don't all make you feel the same way. So there's amphetamine stimulants, amphetamine category of stimulants. That'd be things like Adderall, Vyvanse, Evykio, Dexedrine, very old one. So that's one category. And then there's the Ritalin methylphenidate category. Ritalin, Focalin, there's some other brand names. I hardly end up going all the way down the road of all the different methylphenidate because, and those more than you asked for, but for adults, the amphetamine drugs tend to work a little bit better because it activates more dopamine receptors than the methylphenidate. So you get more, I guess you get more dopamine release with the amphetamine ones. That said, they can also be a little bit more stimulating than the methylphenidate. So I call the methylphenidate category a little kindler, gentler. I've had some patients who couldn't tolerate the amphetamine stimulants. They made them feel too amped up, trouble sleeping. These are also other side effects I didn't mention before. Loss of appetite, which some people like, but then people who don't need to lose weight can end up not liking the fact that they can't eat, and then they're looking really thin. I think that the methylphenidate tend to do that less. Okay, long answer to that medication question. I hope that helps. All right, Roman Jeremiah, thank you for the super chat. Thank you so much for all your videos. You're welcome. Can you advise if TRT, testosterone replacement therapy, is compatible with bipolar disorder type 2 and ADHD? Okay, the quick answer to that, Roman, would be yes. There isn't like some known or just typical, we call them contraindications, when something, it's not advised that someone takes something with something else. As far as compatibility though, like would it cause a problem? So with bipolar disorder, with the testosterone replacement therapy, if you don't replace your testosterone, it could make your bipolar disorder harder to manage because low testosterone levels can look like depression in men, it's men who get that, but can look like depression. And not exactly the same kind of symptoms, but it can be harder to get to feel like you're coming out of the depression if you also have low testosterone. So you kind of want to have your hormone levels be brought to normal levels as possible for optimal functioning and optimal treatment of anything mental. A way it can go, one way that it can complicate things though, is the best way to put this, is too much testosterone can cause irritability and increased aggression, and which could then perhaps look like mania, or maybe even if you were in, I don't know about triggering mania per se, but if you were in a manic state or hypomanic state, if your testosterone was too high, it could make then your mania or hypomania harder to treat as well. So there would be a strong need for there to be a lot of oversight between your psychiatrist and the doctor prescribing the testosterone to make sure that there's a balance, so that potential side effects of your testosterone replacement therapy isn't interfering or aggravating your bipolar disorder, whether it be the depressed phase or the manic or hypomanic phase. Because depression, people can become irritable in depression as well. And so, if you were getting irritable, like, is that because of your testosterone status, or is that your depression needs to be, your bipolar disorder meds need to be adjusted? So, So it's just a matter of your psychiatrist being aware that you're getting testosterone replacement therapy and kind of keeping that in the back of their head when symptoms come up to sort out, okay, which is causing what. It may not always be clear what the answer is, but looking at a timeline of your medication, what dose you're on and were there any changes, and now here you've got this going on, like that's kind of how they would try and figure that out. As far as ADHD goes, I can't think of a scenario where it would interfere or aggravate ADHD, except again, going back to the dose being too high, that's not usually the case, that people end up getting too much. Often, at least in my experience, observing people on testosterone treatment, because I don't treat people for testosterone deficiency, is that people I've seen, they have trouble getting up high enough dose. It's like, okay, you increase the dose, I'm good, but then they dip a little again, and then they got to keep getting the dose increased more so than they get testosterone replacement therapy, and they're just like bouncing off the walls because it's too high. What was I going to say about that? Oh, but just as low testosterone can interfere with can make you have a low mood, irritability, it can also cause some brain fog that then could mimic your ADHD symptoms. So if you already have ADHD, and then you've got brain fog on top of that from low testosterone, then it's the low testosterone state that causes a problem for your ADHD more so than getting that testosterone replaced. So moral of this story is, in general, unless you've got some exceptions here because of other medical issues, it would be ideal to have your testosterone replaced, to get your low testosterone level, state treated for optimal treatment of your bipolar disorder and ADHD. Like both of those will be happy if your testosterone is normalized with replacement therapy. All righty, what we got next? We got my email. If you want to be a part of my email community or email list, where I send out weekly, mostly weekly, sometimes I miss a week, but mostly weekly information, and try and keep you up to date on things, you can go to getmentalhealthtips.com, and that will put you on my email list to stay connected to me. Okay. Isai, I hope I pronounced that right. I say, Dr. Marks, let me just thank you for your videos on different platforms. Definitely helped and still help me. You're welcome. Thank you. You just have that sense of safety, that vibe. I really appreciate that. Thank you. I like having that kind of vibe. Want people to feel safe. Christina Rainbow, I think you're an amazing person and you have helped me. Thank you. You are so welcome, Christina. Thank you. Use, sorry if I mispronounced that. You're awesome, Dr. Marks. Your content is so informative. Thank you. Wow. I'm not good with compliments. It's like a love fest. No, I mean, I really appreciate it. I need to get better at like accepting compliments. Okay. Revealing some of my issues here. All right, Jules, thank you for the super chat. In addition to seeing a therapist twice a month, taking antidepressants, and working out twice a week, what more can I do to invest in my mental health? Okay, very good. Well, good for you. So you're taking antidepressants, working out twice a week. I would say the next two big things that don't have anything to do with medication are your diet and your sleep. So those are kind of like the big three: exercise, diet, and sleep. And those all sound non-exciting and maybe even boring, but that you just can't get around it. So when it comes to diet, you're looking at maximizing or having as clean of a diet as you can. So eating food as close to nature as possible, reducing additives and preservatives and things like that. So people will say you want to, when you go to the grocery store, you want to shop the perimeter and spend less time in the center where all the packaged goods are. Hey, I love some barbecue potato chips like the next person, and it's hard to resist that stuff. But those, sadly, our westernized diet is just jam-packed full of unhealthy stuff. And also, unfortunately, it's much easier and cheaper to eat bad food than it is to eat healthy food. It's a lot of work to buy fresh food and cook it than it is to just go through the drive-through. But so it doesn't have to be all or nothing though. So it's not like you can never, for me, it's not like I'm never going to have a potato chip, but I want to keep that stuff to a minimum. So, you could start out if you have if you haven't pressed the brakes or pumped the brakes on any of your eating, start small, couple of days a week, try and eat cleanly, maximizing your vegetable intake. We don't eat enough vegetables in this country. Maximizing your vegetable intake, try and maybe you could start with adding, if you don't eat vegetables at all, at least one vegetable meal. But if you already eat vegetables, maybe add another vegetable to your current meal. So you have 2 vegetables. And then maybe singling out a day or a couple of days a week where you will not have anything packaged that's not a whole food based. So, you won't have any crackers or something, that I'm just kind of brainstorming out loud here, but start with cleaning up your diet and having set aside days where you're going to eat whatever free, like whatever it is that you eat that you recognize is not good. Don't eat that on like a couple of days a week or something until you can get to the point where it's predominantly gone from your diet, but maybe you have some days where you indulge. Then the sleep, it would be about prioritizing your sleep so that you plan for it. So instead of sleep being something that happens when you are finished at the end of the day, it becomes something that you focus your whole day around. So let's say your bedtime it needs to be 11 o'clock because you need 7 hours of sleep. And so you get up at 6 and get off to work and so on and so forth. So if you know that you need to be unconscious by 11, then you need to plan an hour before that at 10 to start winding down, because you don't want to say bedtime is at 11. So at 10:50, you're getting in bed or you're brushing your teeth to get ready to go to bed. So you want to start an hour, you want to have an hour wind down. So that first half an hour can be just like, whatever you do to prepare for bed, you're turning off television, you're brushing your teeth, putting on your clothes, whatever you do. And then that second half hour is in the bed with the lights off, trying to go to sleep, because the average amount of time to fall asleep, which is called sleep latency, is between 15 minutes and kind of 30 max. It's really 15 to 20 minutes, but I just say 30 max. If it takes you longer than that, then you have sleep onset insomnia. You have trouble falling asleep. That's how long it's supposed to take us to fall asleep if our bodies are ready to fall asleep. If you get into a routine, your body should let you fall asleep if you're lying there in the dark. So that's 10:30 to 11 is in bed with the lights off. I start wearing blue light blocking glasses 2 hours before I want to go to bed, and so let's say my bedtime is 11. It's not really, it's supposed to be 10. But anyway, I'll put on my blue light blocking glasses at 8 because I do want to go to bed by 10. And why do I do that? Because even our compact, what do you call it? Compact flash. That's not the right word, but the lights that we have in the house emit a certain amount of blue light, those fluorescent lights. And the more blue light you have in your home, you could have some big old, monstrosity television emitting all this light too, negatively affects your melatonin production. So it kind of delays the onset of melatonin, which is kind of the signal to your body that it's time to go to bed soon. So these are like little tweaks you could make, even if you're someone who you say, well, I sleep well. I would still say reinforce that good sleep by having a sleep plan, like it is actually something you plan for. So you plan a bedtime, you plan a wind down time. The glasses is just kind of an extra thing, but I do think it makes a difference, especially if you're one who in the evening use your phone or a tablet. And even if you put your phone on night mode, I still think you're still better to get that blue light blocked. And then I was going to say one more thing about optimizing. Okay, so those are kind of natural things. Something you could look at or look into. I did a video talking about magnesium, but magnesium is one of those minerals that it's easy for us to not get enough of, and magnesium is very instrumental and it's one of those minerals that is very important in the production of certain neurochemicals like serotonin, dopamine, and all those. And so people who have anxiety actually have been shown to waste magnesium, meaning your body gets rid of it faster than someone who doesn't have anxiety. So magnesium has been shown to be beneficial in people who have depression and anxiety. And chances are you do not get enough of it with the food that you eat. Now, you don't have to take supplements, but you could also look at making sure you eat that your diet that we talked about before is high in magnesium containing foods like green leafy vegetables, which is why you could add another vegetable to your plate. And also pumpkin seeds is a very high has a very high concentration, it's blanking, a very high concentration of magnesium for the small thing that it is. And so you get a lot of mileage out of like becoming a pumpkin seed eater to snack on. So those are some things to start with. All right, name. Thank you for the super chat, name. How to treating ADHD symptoms without meds in a patient with thalassemia B minor, a blood disorder that causes insufficiently oxygenized red blood cells. Studies show thalassemia can cause ADHD. Okay, so first of all, name. Thank you for explaining to everyone what thalassemia B is. So another way of saying that also is that it is a cause of anemia for people, which with anemia, you can feel fatigue and listlessness and things like that, brain fog and all of that. Okay, so, I'm not familiar with studies showing that thalassemia itself causes ADHD. I'm not saying that doesn't. I'm just saying I'm not familiar with that. I could see how the anemia could make people have difficulty focusing and remembering and whatnot. But as far as actually causing the disorder, okay, I'll take your word for it. As far as treating the symptoms without meds, so a non-medication, okay, so first of all, it would be, one approach would be trying whatever interventions there are to treat the thalassemia. Okay, so if we take that off the table, let's say that's done, check. Treating ADHD without medications typically involves you could get coaching for executive function. There's lots of coaches out there. In fact, I'll shout out to my buddy Sean McCormick, and he is with I don't have his website up. I'll probably put it in the notes. He's an executive function coaches. Sorry, Sean, I don't have your website by heart, but it's like EF specialist, I think is the website. But there are lots of executive function coaches out there that could help you with seeing what the deficits are, like seeing what the problems that you have are, and helping you come up with some strategies to overcome those things or work with those limitations, whatever they are. So let's say, so for some people, I'm not sure if necessarily a coach would say this, but maybe they would, but body doubling is kind of a common a thing that can help people. What's body doubling? It is having someone who's working on something sit with you, or in our age, it could be FaceTiming or some other way that you can see this person and they're doing work on their end and you're doing work on your end. And just having this other person, knowing that somebody else is there working like you're working, can help you focus. Now, that doesn't work for everyone, but it can help for some people. And I've had some people tell me they really like doing that now that they've started doing it. It can help with the motivation. It may not necessarily help you stay focused on what you're doing if what you're doing is something you don't want to do, but it can certainly help with the motivation. Like you're kind of accountable to this person and they're sitting there working. So, okay, I'll keep going. One thing I talk about in a video that I did on, take a look at my ADHD, I forgot what I called it, skills training or something, I think is what I call it. It's a playlist. It's not that many videos in there. But I talk about setting up a reward system where you tackle tasks that you don't want to do because there's a reward coming and you're trying to get to the reward. So if I do this thing, make this list, right now for me it's gathering forms for taxes, searching on all these websites to get the 1099. I can't stand that. So, but if I put in front of me, okay, I'm just gonna, instead of keep putting that off, if I take the 20 minutes or whatever it's gonna take for me to do that, let me just do this. It's gonna be unpleasant. I'm gonna be irritated while I'm doing it. But then afterwards, I'm gonna go and do this other thing. So I'm just doing this because I'm looking forward to doing this other thing. And that other thing is what kind of pulls me through to get me to just go ahead and do this thing that I keep putting off, just as an example. But that's kind of an example of kind of a coachy kind of thing. So yeah, I would look into executive function coach to help you come up, or this person come up with some strategies that are specific to the things that you struggle with the ADHD. All right, thanks for that question. All right, so F Teppen, I don't want to botch your name. Thank you, F. Lots of love and Belgian chocolate greetings from Brussels. Thank you. My late mother-in-law was from Belgium, and yeah, miss her a lot. But yeah, we heard about Belgium all the time. Cancer advocate. Hi, Dr. Marks. Thank you for your work and know that you are an inspiration to me. You are welcome, Cancer. Thank you. It's for people like you that I do this. Lisa Willis. I wish I could get my 20-year-old son to see the importance of a schedule. Still the hurdle to work on. Yeah, I know. I hear you. I wish I could get my child to on a schedule. And even though I talk about all this stuff, um, I'm the one like, okay, you gotta do this, you gotta do this. And I realized I probably am not helping him get on a schedule because I'm towing the line with reminders and reminders and reminders. But you know, and that's kind of the world of the mother, life of the mother. But um sometimes, since your child is 20, sometimes this stuff is better, it's better accepted from a coach, like an independent person who has no skin in the game, who's just trying to give them some tips. And you know, since I don't do executive function coaching per se, I don't know if there's, you know, if the structure is such that someone could get a lot out of 3 or 4 sessions and be done. Like, it's not like, you know, getting in psychoanalysis where you're just gonna like, it's gonna be years of this. I do think it's focused enough that people could get some strategies. Now, granted, they'll have to implement them and be consistent. And some people, I guess, can stay in coaching because they need that accountability and they need someone to keep prodding them, other than mother. So, so yeah, I hear you on the wishing your child could get on a schedule. It's a hard sell. Eventually, though, some people finally get it and see the utility in it and come up with their own version of that. All right, Tanya, thank you for the super chat. My question is, how much is too much medication? I'm currently taking 150 of Effexor, 100 of Lamictal, 10 milligrams of Abilify, 10 milligrams of propranolol, 50 milligrams of, okay. All right, anyway, 50 milligrams of hydroxyzine, 0.5 clonazepam, 150 of trazodone, and 50 of Seroquel. Okay, the fact that I'm tired just reading that. All right, keep this up because I need to break this down. So, Tanya, yes, this is a lot. Now, I got to tiptoe lightly here because I'm not trying to be critical of anyone's treatment, okay? Sometimes people can end up on a lot of medications just because somebody forgot to discontinue something, or you go to a different doctor, or you've got multiple doctors prescribing stuff. And so, no, and people aren't communicating. So anyway, another reason people can end up with a lot of medication is when you have a lot of symptoms and perhaps there's not a clear diagnosis and the person is treating symptom by symptom. And so even though there's overlapping symptoms, it could be covered by one of those medicines, again, without kind of an eye on a prize of this is the disorder I'm treating and I'm just treating symptoms, then you can end up with, well, now I have this, doctor, this is happening. Okay, let's take this. Well, now this is happening. And then, okay, take that. And then you end up on all these meds. Now, don't know if that's your situation. I'm just trying to address this from a general perspective, because this is not, this is typical. I don't know about typical. This is not uncommon. Okay. So now you're taking Effexor, Lamictal, Abilify, propranolol, hydroxyzine. So getting back to your question though, how much is too much? I think it's too much when you've got too many medications in one category. Okay. Now, sometimes it's indicated to be on, say, two mood stabilizers. But in your case, let's say you're taking Effexor as one antidepressant. Okay, so you're on one antidepressant. Trazodone, you're probably taking for sleep. You're taking 3 different mood stabilizers: Lamictal, Abilify, and Seroquel. My guess is because of that small amount of Seroquel, it's for sleep or maybe anxiety. So now you're talking 2 different things for sleep. maybe you switch those in and out. I have some patients who we kind of have a long list because sleep stuff will wear off, the effect will wear off over time, and you end up needing to switch around, musical pills. So take trazodone for a while, it's not working anymore, you stop that and take Seroquel. So if that's your case, then those two would kind of be looked at as one. If you're taking both at the same time, the clonazepam 0.5, I'm guessing you're taking that for anxiety or maybe sleep. Sometimes people will take it just at night for sleep. So let's just assume you've got this cocktail at night of Klonopin, trazodone, and Seroquel. So even though those aren't all in the same category, there's still 3 different medicines for sleep versus one medicine for sleep that you take at a time. It'd be different if you're kind of switching those in and out. But if you're taking 3 things for sleep, my opinion, that's too much. I think it should be narrowed down to 1 or possibly 2. If this is hypothetical, but if I were treating you, for example, you came to me on this regimen, first thing I would do is see what you're taking, why you're taking these things. Like, what is this for? What is that for? What is that for? And then I would look to aim at kind of trimming down in a way that, let's say, if we're treating bipolar disorder, then, or, I don't know, if we're treating bipolar disorder and anxiety, let's say that combination, I would look at trying to get you down to like no more than 2 mood stabilizers for your bipolar disorder. And then you might need something else that's separate for your anxiety. Propranolol, we talked about that being typically what we'll use for anxiety. But then you've got hydroxyzine, which is also for anxiety. But then you've got Klonopin, which can also be anxiety. So again, look at anxiety issue and try and keep you at 2, preferably 1. I mean, ideally 1, but everybody can't get by with just 1. So look at maybe no more than 2 for that condition. So I guess kind of a summary version of what I've been rambling about is looking at the conditions that you're treating and trying to get to just no more than 2 per condition is a good approach. Now, if I get under the hood here and look at what it is you're being treated for and all that, my answer could be different because there could be stuff I'm missing. Just kind of bird's eye view of all of this. My initial response is, I think, having more than 2 pills per condition is a bit much, and can lead to just more side effects and even more drug-drug interactions. Every time a new doctor adds something, like let's say you've got high blood pressure, let's say it's nothing mental, you've got high blood pressure, now you've got to get put on a blood pressure medicine, that doctor should know all your other medicines and put in, put them into an interaction checker to make sure that the medicine that they're adding doesn't negatively impact one of these meds. Like every doctor at this point going forward is going to need to do that every time they add something. I mean, they should be doing that anyway, even if you're only on 2 drugs, but it gets more complicated the longer the list goes. All right, I hope that helps, Tanya. Okay, I don't have my glasses on. I think this is Ali. Excuse me, Ali. Iha. Thank you for the question. I mean, thank you for the super chat. I really appreciate it. So, what indicate ADHD and psychosis are occurring? And if one is caused by dopamine deficiency and one is by excessive, how can they occur together? Okay, so I'm thinking your question is, what can cause ADHD and psychosis to co-occur? And if one is caused by dopamine deficiency, the other Excess. Okay, so I'm glad you asked this question about dopamine. I know there's been, I mean, it's popular to talk about lacking dopamine. One thing to keep in mind, though, is that dopamine production happens in different parts of the brain. There's different pathways to dopamine production. So those pathways determine the effect of the dopamine. So with ADHD, you've got a tract that goes from your brainstem up here. I'm actually have pictures to show you. I wish I did, but anyway, up through to your frontal lobe or the prefrontal cortex, and dopamine depletion or less dopamine there is what contributes to ADHD. I won't say causes because it's a little more complicated than just there's less dopamine, you got ADHD. I mean, there's other factors, but let's just say one of the big contributors is less dopamine in the prefrontal cortex. The excess dopamine that's associated with schizophrenia is excess dopamine in a different portion of the brain. So it's not just kind of a global lower dopamine level and this stuff happens, or increase it and this stuff happens. It just depends on what tract it's called, or pathway is being affected. So when someone takes antipsychotic medications, the idea is to reduce dopamine in the areas where it affects schizophrenia or causes schizophrenia and the psychotic symptoms. However, reducing the dopamine in those areas helps the schizophrenia or helps the psychosis, but that low level of dopamine in other parts of the brain that affect your muscular movement is what's responsible for the Parkinsonian effects that we can see with the antipsychotics, where people can move slowly or have kind of the stone faces with very little facial expression, or even start to have like the tardive dyskinesia with the slow movements, or even muscle stiffness. So all that to say, you can have co-occurring ADHD and psychosis because dopamine does different things in different parts of the brain. It is not that uncommon for someone with a psychotic illness to also have ADHD. Psychosis is a general term, so it can occur as a primary disorder in something like schizophrenia or delusional disorder, but it can occur as a symptom of a bigger problem in something like depression. You can have a psychotic depression, which is an indicator of the severity of the depression. So people who are severely depressed can become psychotic. It's like being hot depressed, psychosis. Same thing with mania. You can have psychosis with mania, but psychosis isn't your primary illness. It's just a symptom. You can get psychosis with drug addiction, certain drugs, certain medications. Someone could get a high dose of steroids and have psychotic symptoms. So yes, again, summary. I always have to give summary because I know I go on. Summary is you can have psychosis. Dopamine acts differently in different parts of the brain. You can have low levels in your prefrontal cortex that contribute to ADHD. You can have low levels in parts of your midbrain and things that contribute to Parkinson's disease or Parkinson's symptoms if you're taking a medicine that does that. You can have elevated levels of dopamine in other parts of your brain that cause psychotic symptoms. All right, thanks for that question. Okay, Cheapy 78. Sorry if I mispronounced that. Thank you for the super chat. I have stopped taking my bipolar meds after finishing a month-long ketamine treatment program. I also feel no need to take lithium again. What's going on? What questions should I ask my med provider concerning alternatives to lithium? Thank you. Well, first of all, congratulations. That's wonderful that ketamine did that for you. As far as helping you be symptom free to the extent that you don't need to take your medications. I think I have had a couple now of people with bipolar disorder patients who got ketamine at first, before ketamine has become more and more popular. I think some centers anyway were only doing it for unipolar depression because the jury was still out onto how beneficial it would be for bipolar depression and whether or not it would trigger mania. So I'm seeing now that a trend, even with people with bipolar depression being able to get ketamine and it being beneficial, not being able to get it, but I mean, yeah, being able to get it, but also that it's beneficial and not triggering mania and making their bipolar disorder worse. Okay, so now where do you go from here is kind of what this question is about, which is you should see this as if you have bipolar disorder. As I mentioned earlier in the stream, bipolar disorder, as is depression, is a recurring illness. It is not, I mean, I'm sorry to say that, but it is not something that you can get this blitz of some kind of treatment and it's gone forever. Now, how long it will take for symptoms to come back is variable from person to person. So it could be months, it could be years. The inter-episode period is variable from person to person. So you still, if you're not on anything, you need to be very vigilant with looking for symptoms. That means having a good understanding of what your prodrome symptoms are. If you want to understand more about that, I have a video talking about that on my bipolar playlist. I also have a bipolar guide that is digital. The print version is on Amazon, where I kind of talk in more detail about that. But it becomes about being educated about what your early symptoms look like so you can see an episode coming. Okay, so that you can get treatment really quickly. Now, whether that treatment ends up being ketamine for you, if you want to return to that, or just regular standard medications, then that would be the time to like do something before the episode gets out of control. But probably a better approach, given that this is not an illness that or disorder that goes away. It's just now you don't have symptoms and you're in remission. A better approach would be to get on something maintenance to stay in remission, to keep you out of an episode. You said you don't want to take lithium again. Okay. There's a lot of other medicines out there. I don't think that it should be a big ask or a big statement to say to your provider you don't want to take lithium. Lithium's a great drug, okay? No question. But it's not for everyone. Also in that bipolar playlist, I have a video talking about who is best for lithium. But in a nutshell, it's people with more classic symptoms, where happy mania, clean separation between episodes, so you don't have like this chronic level of low-level depression in between episodes. And also people who tend to have had more manic symptoms seem to respond a little better to lithium. So at any rate, it should not be a big ask to say, I don't want to take lithium. What else can I take to keep me in remission? Now, the other options, though, probably the one with the least side effects would be lamotrigine. It is an anticonvulsant. We use it as a mood stabilizer. Psychiatrists use it as a mood stabilizer. It kind of has a subtle effect, I think, in the sense that it's not like you take it and go, oh yeah, I'm so much better. It's more like you take it, and I've had some patients be like, after a while, like, I don't know what this is doing for me. Can I get off this? We get off of it. They have a dip, and they're like, oh, okay, now I see. All right, I'll get back on the lamotrigine. So it kind of has this more in the background effect, but still, some people can be maintained on lamotrigine as the only agent that they take. We call that monotherapy, and be fine. And it keeps symptoms at bay. Now, what could end up happening is you get on something like lamotrigine. There's a buildup process. It takes about 6 weeks to get up to a therapeutic dose, by the way. You get on it, and like now, while you have no symptoms, it would kind of be a good time to like on board with lamotrigine. And then, and what could happen is you could still have some breakthrough symptoms because not everyone can handle monotherapy. Some people need 2 agents or even 3 agents to manage their bipolar disorder. Some people need can kind of go on off stuff. So you take this one medicine like lamotrigine as your baseline medicine. You have a dip, so you have some breakthrough depression symptoms, and then maybe your doctor then adds on something, or you have breakthrough mania or hypomania, even though you're on the lamotrigine, and your doctor adds maybe another mood stabilizer to bring you down. And then once that passes, those symptoms pass and you're kind of back, then they could take off that thing that they added so that you're back on the lamotrigine, or you could just stay on it because you just feel more comfortable with that. I would say lamotrigine is probably the easiest thing to get on and stay on as a way to control and keep your symptoms from coming back, or if they do come back, only come back mildly. Other options would be things like the antipsychotic medications that we use as mood stabilizers, like Latuda, Abilify, quetiapine, Seroquel, great, but a lot of weight gain. So all of these meds that I just mentioned, the antipsychotics, have a lot of side effects. So they work very well, but you get more into side effects with those medications. And then last point about this, there are other not antipsychotic, anticonvulsant mood stabilizers, Depakote, Tegretol. Both of those have been used for years to treat bipolar disorder. I tend not to talk about them a whole lot or mention them much because they're good, but you do have to get blood work. You've got to make sure kind of like the lithium. So if you're fine, like going and getting your blood checked and all that, then that should not be a big deal. But I guess I just kind of work with a lot of people who don't want to be bothered with that. So for lamotrigine, because you don't need blood work for that. But the Depakote, valproic acid is the generic name. You need to get regular blood work to check for like not only the level, because there's a window, therapeutic window, just like with lithium, but other side effects like low platelets. I've seen some hair loss with Depakote. That was minor, though. I mean, not minor. Hair loss is not minor, but that was a minority, a very small minority of people who had that problem. Tegretol, I tend not to use that much after I got out of residency because it has more drug-drug interactions. So just like a previous question, we were looking at that long list of meds, and I was saying, every person who prescribes you a new medicine's got to go through that list with you. Tegretol tends to not play well with some medications. So it's more drug-drug interactions, such that, if you got on it and it did well for you, then you kind of might be eliminated from taking other stuff in the future because it interferes with your Tegretol. Or Tegretol can also cause low red blood cells, which is pretty serious. situation. So you got to, get blood checks with that too. So that's that. All right, Rushman. Just wanted to give a big thanks. You've been incredibly helpful to not just myself, but especially in helping my friends and family get a better understanding of my bipolar 1. Truly thankful. Perfect. Thank you. What you've just articulated is exactly why I do this. I want people to be able to better understand themselves, but also I want other people involved in your life to help to be better able to understand. And then more globally reduce the stigma and all of that of mental health by having it not be such a black box. People are afraid of stuff they don't understand. So the more people who can understand, then the less fear, judgment, and all of that. And that's why I do this. So you are welcome. I'm glad what I set out to do has worked. Miss Naya, I love that you do this. Thank you. You are welcome. You are welcome. Daryl, because of your sugar video, my A1C is now 5.9. Knocking on the door. Is that because your door's wood? Great. Excellent. Good. I'm glad. I wish I could be a little bit more disciplined. I go back and forth with sugar. I go off of it and then rebound. But anyway, great for you. All right, Tracy, we've got the same name. Where did you get your eyeglass frames? Where did I get my eyeglass frames? First of all, these are old. I got them from Lens Crafters. They're a couple of years old. Yes, they're red. Let me see. I can't see without them. I want to say they're Donna Karen. No, they're Coach. They're Coach. I had some that had the plastic nose thing, and that hurt. I'd take them off and I'd have these dents. That's not gonna work. So anyway, these are nice and comfortable. They slide on and off easily. Since they're readers, I can't see with them, I don't want to be doing this. So anyway, so yeah, long answer, Coach from Lens Crafters. Thanks for that. Okay, Heavenly Presley, thank you for the super chat. I have bipolar 2 and CPTSD from abuse, SADV, not sure what that means, okay? Biggest issue for me is paranoia, that I can't control things or something will happen to me. And I guess that gives you panic is what you're saying, or that you'll get panic. So, okay, let me go back. So you've got bipolar 2 and CPTSD, which CPSD, for those who don't know, is chronic PTSD, which really is not an official diagnosis. PTSD is an official diagnosis. The chronic nature of it is is more of a psychological concept or construct of people who develop a trauma response in response to as a result of long-term, consistent, or repeated trauma. The significant difference, though, is PTSD itself has a certain look to it. Flashbacks, lots of vigilance, avoidance, blah, blah, blah. CPTSD, because the idea is that the trauma affects you early in life during your formative years of your personality and things, that it affects your personality. It kind of gets weaved into how you see the world and how you respond to the world, and basically your personality. So that's different. That's a different look. Someone with CPTSD has a different look and effect than someone who is, say, a full-grown adult, and then they get into a car accident, and now they have PTSD around that single traumatic event. Okay, so I just want to explain that. So now, back to the question. Yeah, bipolar disorder, bipolar 2, CPTSD. and I'm not sure about the SADD, but I probably don't need to know all that. Biggest issue is paranoia, that I can't control things or something will happen to me. So my thought about that, Heavenly Presley, I hope you're in therapy. I know that therapy is easy for me to just say that, but therapy isn't always that accessible to people. But because the reason I say that is because your bipolar disorder, think of it, I know I've used this analogy a bunch of times. Think of it as like a storm going through, and your CPTSD is more like the climate, like it's there and it's there. But, if a storm passes through, the climate affects how that storm is expressed. So if you're in a super cold climate, the storm, you might have snowstorms and stuff. I'm from Florida. Our storms are mostly hurricanes and rain and stuff like that. Very little snow. So your bipolar disorder is not necessarily going to be responsible, so to speak, for your paranoia. It could if you were manic and then, had psychosis attached to that mania or depression even, and had a psychotic episode. But if you're talking about kind of general everyday paranoia, that probably has more to do with your CPTSD. And that is going to take, I think it's going to take a professional helping you dig out from under that to see how you can overcome the paranoid thoughts. Overcome in the sense of have that not be your knee-jerk response to things. Because let's say, I'm just trying to think of a quick scenario. Let's say part of the abuse was a caretaker, doesn't have to be always a parent. I feel like I'm always blaming parents, but a caretaker, older sibling, or even, people you were exposed to, at a young age, who you were consistently exposed to, who made you feel unsafe because they're worried about stuff. So they project that onto you. You can't do this. Very maybe even very protective and not even letting you do stuff because the world's an unsafe place. So this is what they pass on to you. That's not necessarily abuse, okay? That's more of a just, kind of family dynamic thing. But and maybe maybe where the abuse could come in this example is putting you down all the time when you try and kind of step out on a limb and and be brave and try something, and they're like, what are you doing? Why are you even doing that? Stupid, you shouldn't be doing that kind of stuff. This is, you're not good at this and that, and I don't know why you tried to do blah blah blah, whatever. Very disparaging comments, discouraging you. And it might be because that person isn't brave enough to do that stuff. They see you doing it, so they're going to hold you back. Okay, don't get me started. Anyway, so if you kind of grow up with that sense of, what if this? If I can't do this because people will do this, or I can't do that because people do this. I don't know if that's what you mean by paranoia, but this kind of fear of persecution in some way. Why do you fear that persecution? Because it was taught to you to fear persecution. You were persecuted because you'd be criticized or torn down, or maybe even punished for doing stuff that you were just exploring, or you were just trying to express yourself, and you get torn down with criticism or go to your room, or whatever that looks like. You can then step through life fearing lots of stuff, just kind of having this free-floating fear all the time, which one could argue is, paranoid thinking in a way, not kind of what we think of as psychotic paranoia, but fear of persecution. So a professional could help you see that pattern, even if you recognize that pattern. This is because of this. How do you then break through that and process that and be able to see things differently as an adult now who's got more control over things? And some people will call this reparenting. There's not just kind of one thing to do. I do think it would take someone helping you see the particular vulnerable areas that trigger this paranoia or that make you feel uncomfortable. It may be limited to certain types of things you do, like you relationships. You have trouble staying in relationships or feeling comfortable in relationships because you're constantly fearful that the other person's going to leave, or that they don't hold you in very high regard. And this doesn't have to necessarily be a romantic relationship. It could be friendships, colleagues, even. Like, you just are constantly believing that people don't have your best interest in mind and are there to harm you in some way. And at some level, you recognize where this is coming from. You might not, but you might, but still just can't make yourself not think that. Like the first steps would be recognizing these vulnerable areas. Like, what's the pattern here? What's the circumstance that makes you think this? You can start by kind of writing these out, journaling. When you start to feel paranoid, what's the circumstance? Write that out. Was it something someone said? Something someone did? Was it something you were expected to do? And then also write out, what is your fear? What do you think is going to happen? Once you kind of get, and then just kind of go day to day and keep coming up with these scenarios so that you can get you and someone can get a bird's eye view of what's going on here. Are there patterns? Are there things that really trip this up for you? Or is probably not just this general every day, doesn't matter what the circumstance, this is how it is. I doubt, well, it might be, but I doubt I bet you, if you really kind of dig in, you can see that there's certain scenarios, and you might be in those scenarios a lot, but it's certain things that really stir this up for you. And how can you minimize your exposure to those things? But then also, how can you reaffirm yourself in a way that you are not responding to these scenarios like a child, and responding to it as the adult that you are, and with more control than you believe you really have. That's kind of a generic answer, but I think that's a good place to start with with getting kind of an understanding of where this gets, how this gets activated, and then getting probably a therapist. If you don't already have one, you might already have one, to help you with that. She says, yes, constantly put down my whole life, abandoned by my parents, sexual assault. Yeah. So, gosh, I'm sorry. So yeah, that's a lot. That's a lot to unpack, but you can do it. And I do think, I will say this, I do think a measured approach is as far as what you should expect the outcome to be. My opinion is, and granted, I don't do trauma therapy enough, or I don't do trauma therapy to be able to say, yeah, of the 1,000 people I've treated, this is what happens. But I think kind of realistically, I mean, I've treated people with trauma. I just haven't been the trauma therapist. I think a desired outcome, a reasonable outcome, is get to where you're able to think about these past incidences, still feel some amount of pain, disappointment, loss, things like that, but it's more on an intellectual level, similar to how I would think about this if you told me. Like, if you I mean, just even me reading that, I'm like, gosh, that's awful. But I'm not destroyed by it. Like I'll still be able to get up and, work today because it didn't happen to me. So a desired outcome for you as the person who endured this, instead of being shrouded by all of these negative thoughts about it and having, kind of drowning in all the things you missed out on, all the things like hearing what people are saying, like having this repeat in your head the things that people are saying, or even re-experiencing the assault and feeling the shame from that, all that. Instead of all of that going on, you're better able to recall them with less of that intense emotions around it, and it's more like just a recollection with a little bit of negative thought attached to it. That's, I think, kind of the ideal scenario, because you're not an automaton. You're not going to be able to just have no emotions or experiences. That's not even realistic. We're emotional beings. The goal is just to not have the raw emotions that kind of haven't really left. Not be so raw, be healed over enough to where you can acknowledge them and maybe even feel them a little bit, but they don't dominate your thinking, and they don't keep feeding into how you see your current self, because that's the other part of this, especially with the CPTSD aspect, is it weaving all of that negativity, weaving itself into the fabric of who you are. You've got to like pull out those bad threads and reconnect as someone you feel good about, who's still flawed. So you're not looking to like not have anything be wrong with you, but you can still like affirm yourself without needing, and validate yourself without needing other people to do that for you. Because when you're super vulnerable and super broken, you need everything to kind of reaffirm you, and you want to be able to have that come from within. All right, I know it sounds kind of fluffy, but all right. So this is it, Evan. I love your videos. They are so helpful. Thank you, Evan. Thank you. And Nori says, I am so grateful for your help here online. You are welcome. You are also very welcome. Thanks for coming. I enjoyed this. Don't forget about my email list. Getmentalhealthtips.com is a way you can stay connected to me. And for my weekly newsletter, mostly weekly. And I don't have a plan for doing this next month. I've got some other things going on next month, but I do want to come back and do some more lives at some point. But in the meantime, I have the other videos coming. I'm still producing videos. All righty. Take care. Bye-bye.